There you are, Nada.
Excellent. Hi, nice to meet you, everybody. I'm going to try and kick off this session very quickly because I'm conscious of the time and I'm very interested in a robust panel discussion. So what I wanted to present today, after I've been asked to kick off this meeting, is intersectional gender equity in medicine as a public health need. And although there will be some reflections on my life and my experiences, this is where I feel my work is most important. I'll briefly give you my story, and I put this picture up, even though it doesn't include my youngest third child, but the picture is really to show that for me, even in my own home, I'm a bit of an oddball and I stand out as different. I'm biracial, I'm a third culture kid, which means that I was born somewhere different to where my parents originally come from, and also have traveled around, so I don't really necessarily align with a particular culture, language, or ethnicity. I'm multilingual, I speak four languages, and I've lived mostly around Europe, in the Middle East, in North America, and Australia, and New Zealand. And as I was growing up, you know, I felt that the world was my oyster. I could go anywhere and I could do anything. And that's because I got to move around a lot and see a lot of the world. And I'm very grateful for that experience, even though many of you would say, you know, how did you manage to do that going to school? So, you know, the reason I really love that experience now that I'm older and wiser is that, you know, everywhere I went, I felt a fish out of water. You know, sometimes I was the only woman, sometimes I was the only Black person in the room. And sometimes being a fish out of water was good, and sometimes it was bad. So when I traveled to Japan, people looked at me like, you know, I was a monster and I was really big and very loud. And so there was a lot of kind of, you know, fear and certainly not a lot of warmth around, you know, my difference. And in some places it was almost fetishized. And, you know, when I lived in the Czech Republic, I was very exotic and novel, and people wanted to meet me and get to know me and learn a lot about me. So there are times when being a fish out of water is a good thing, and sometimes when it's not. And certainly my experience in Australia is somewhere in between. And over time, going in through medicine, I had many feminist epiphanies, because for many of my earlier career experiences, I was the only woman in the room. And you know, after a while, I started to notice experiences that made me feel like ethnicity or my color made a difference to how I was perceived or how I was treated. And then I developed some anti-racist epiphanies. But I kind of want to share with you today what I call intersectionality, and why I now believe an intersectional approach is the best approach. Because, you know, sharing with you today some of my experiences, I want you to hear that it's a journey, even for someone like me who identifies with minority groups, both as a woman and as a woman of color, especially a Black woman. And that this journey is something that we all kind of have to embark on, and be kind to ourselves and consider that we all will make mistakes, and we may not do this the right way, because there's no really right way, but we need to start the journey at the very least. So I'm going to share with you my personal story and where some of these epiphanies came from. I remember with my first child, and this is 10 years ago, the midwives really discouraged an epidural. And I thought, you know, midwives don't want you to have an epidural. That's normal. And I remember some of the comments that were made even 10 years ago. When one of the nurses said to me, your people are good at childbearing and birthing, you don't need that. And at the time I dismissed it. I thought, what does that have to do with anything? But I'll tell you why it mattered to me later. I was denied pain relief after my C-section, after 12 hours of C-section, you know, told that I really didn't need that. I recall falling in the corridor, and one of the nurses passed me by without even helping me up and said, you just need to suck it up. You know, you can do this. My baby was losing weight and not feeding, and one of the lactation consultants said to me, Black people's milk comes in later, it's fine. And of course my baby wasn't fine and was losing weight, and I had to have some interventions further down the track. And it occurred to me that that moment someone said that to me, it actually affected me, because I believed it, not because I felt bad about it. I just said, oh yeah, this nurse knows what she's talking about. And when I came to going home, I was told that the nurses were uncomfortable with the amount of pain relief I was on, so I was only given 24 hours worth of pain relief over the weekend. So there was a day where I had no access to pain relief, and I had to get readmitted into hospital over the weekend. So the reason I bring these things up is because I felt it, you know, 10 years down the track, when I had a conversation, or attended actually a symposium on poor pregnancy outcomes in Black women. And my story was reflected back to me in data. There was some research to show that Black women's pain was minimized and not listened to, and that led to poor patient outcomes and infant outcomes. And it really took me by surprise, because it didn't occur to me there was anything in all the things that I heard during that experience, other than the fact that it was so vividly memorable to me 10 years later, and that it validated my experience. And I felt if I couldn't advocate for myself as a physician, what chance do other people have if who are not familiar with the healthcare sector? So I felt maybe I was failing my patients somehow. And as a hematologist, you know, I experienced many situations when I reevaluated how I was trained and what I was doing in the clinic, that perhaps the science, perhaps the education that I had received had not set me up to manage women to the best of our abilities, to manage the concerns of people of color to the best of my abilities. And these are just some of the examples that I'm putting up here around, you know, some of the concerns women have around iron deficiency. I get them sent to me all the time without investigation of the causes. Standards of care are not applied uniformly to women. Chemotherapy data is generated from mostly white male populations. And so when my patients would say to me, I have this weird side effect, I would often say, well, the data doesn't show any, you know, evidence that this is a side effect of your treatment. And not until very recently, I'm ashamed to say, but very humbled to have learned that actually there are probably complications and adverse events that we are not aware of because the data didn't look in those populations. So my views on this have changed, particularly as a clinical researcher, in how I bring intersectionality and how I bring my experiences, my personal experiences, into the lens by which I look through some of this information and some of this science. And I'll briefly describe what intersectionality is, because I found that in Australia that term is not used very frequently. It's certainly a term that's very common in North America because it's probably where it's originated from. And they've really had much more sociocultural pressures and catalysts to really look at this. And it's a term that was coined by an American critical legal race scholar, Professor Kimberly Williams Crenshaw, back in 1989. And it evolved from historically Black, Latina, feminist, queer, post-colonial, and Indigenous activism and scholarly work that's really quite impressive. And it articulates some complex factors and processes that shape human lives. My favorite quote of hers is, intersectionality is a lens through which you can see where power comes and collides, where it interlocks and intersects. It's not simply that there is a race problem here, a gender problem here, and a class or LGBTQ problem there. And the word that I like to reflect on is lens. It's like putting on glasses that help you see for the first time. And that's certainly what the experience was for me as I learned more about intersectionality in healthcare. And in healthcare, it's become more common to discuss this concept in public health. So the WHO has integrated this into many of its policies and its strategies. It's a framework that focuses on the ways multiple axes of inequality intersect and compound at macro and micro levels to produce a broad range of unequal health outcomes. And, you know, medicine is the same as every other power structure or system, because we're very well integrated and interconnected with law, politics, government, and media. So these structures can promote implicit or explicit biases that can create interdependent forms of privilege and oppression. And I like to use the words privilege and oppression rather than just biases, because it can be demonstrated much more easily when we try and talk about science and data and the healthcare sector. So the first step, in my opinion, is to confront the past and its failings. There are certain truths that we cannot change or shake. Medicine evolved within a white patriarchal framework. And it's also really important that when we talk about gender equity, we recognize that this movement, the gender equity movement, emerged from within a white supremacy movement. Often white female votes or white female agendas were prioritized over race or minority group agendas. And so we have to be sensitive in the language that we use around this. We are human and we are fallible. And societal othering of minority groups is reflected in medicine as much as it is reflected anywhere else. How many times have you or someone you know said that they didn't see color or gender and they treated everyone the same? And this in itself is a problem. I think it's really important, like I said, to put those glasses on and get that lens on to see the richness of diversity in our societies and communities and what that means. And if you've ever experienced othering, I'm sure many of you have traveled and been to different cultures and different countries and felt at some point different to the prevailing population. So that feeling is important to reflect on, because some of us live in our society in Australia and feel othered all the time. And so although it may not affect you personally, it certainly is probably affecting someone you know or you work with. And it's okay to feel uncomfortable about this kind of work, because it's hard work. It really makes us think introspectively and potentially challenges our ideas and moral values in terms of, you know, do we feel that we are moral or in what we do and how we see the world? And I think it is important to acknowledge that it is hard and uncomfortable, but it's important work to be doing both personally and from other levels. I think acknowledging privilege is everything to me. The difference is very clear. Treating people the way they want to be treated and not how you want to be treated is a concept that is only just emerging. You know, we often talk about treat others the way you want to be treated. I say that to my kids, or at least they used to. And now I understand that actually there are populations of groups in society that are very vulnerable, have a different experience of life, and they need to be treated the way they want to be treated. And we can make that leap. We're smart enough as human beings and as a society and a community to be able to do that. And this picture is a very common picture you'll see on the internet. And often you will see the two central panels where we talk about the difference between equality and equity, treating everyone the same versus treating everybody the way they need to be treated to get the same kind of level of quality of care or service. But I want to show you on the left what the reality of the world is. And unfortunately, this is the same in medicine, and it's even in public health systems like Australia, where, you know, public health is free, everybody gets free healthcare. It doesn't mean that people get the same quality of care or the same access to quality of care. And so the reality is there's some people who are really propped up and supported to get to where they want to get to, and others that are either forgotten, missed, or are part of our blind spots as individuals, as communities and societies. And my favorite wheel that you will see depicting power and privilege is this particular one, because it's very colorful and, you know, it really hits home for me as a lens to look through. It's a pair of glasses that you can see through, and it really does enrich the way you think about life and society. And if you look at the center of that wheel, this is who we serve in government, in media, in economics. These are the people who do the best out of what we have to offer as a society and community. And as you move out of the circles, you will see marginalization of communities. And the more marginalized characteristics you have, the worse off you are. And so if you only think about a single characteristic as a group that requires attention, then you're really missing the big picture, because some people are really, really disadvantaged. And I'll go back to that panel on the left where you see they're right down at the bottom, even dug into the ground. And so looking inwards and critically is something I ask everybody to do. I certainly asked it of myself, because I started to realize that even I was conditioned to think a certain way, to be a clinician a certain way, and a doctor in a certain way. And so, you know, I feel the need to hold myself accountable, my profession, institutions that I work in, society and culture accountable. I think clinical education and practice at the moment is inherently biased, because as I reflected back on my experiences, I had to deconstruct everything I learned and think again about how I look at the information that I learned and how I apply it into practice in my clinic and with my patients. I was taught to look at a patient's psychosocial context and learn how to look after them, but really never was taught how to mitigate the impact of sex and race as a negative prognostic factor, or to recognize racial trauma or gender trauma in patients, let alone my colleagues. And as I grow older, I'm starting to notice that level of trauma in the people I work with. And certainly this is trauma that is silent, that is not acknowledged or addressed. And for me as a researcher, research questions and the conduct of research, the implementation of it is certainly very rooted in our own biases as a society and as a culture. And if we don't reflect on those things, we won't be able to try and redress them. And so one of the things that I do every time I read a paper, every time I try and think of research, is to ask whose stories are we missing and who are we serving. And I think COVID has highlighted this more than ever, both in the healthcare workforce, but also in terms of the patients and the people we serve in our society and communities. I'm just going to show you very briefly some of the flurry in the medical literature around the impact of gender and ethnicity in medicine. It's something that everyone is taking much more seriously, but certainly more so in North America, and that is because they had this catalyst with the murder of George Floyd on television that really mobilized the healthcare workforce to become more active in this role and to become more vocal when it comes to the impact of gender and ethnicity in medicine. And this is a movement that is really close to my heart and one that I feel very much aligned with, because I think it is a conversation that we haven't had a catalyst for in Australia and New Zealand, and I feel the need to move this forward like the rest of the world is. I'm just going to quickly go through some offering of information. Inclusive and high quality care for everyone is what we all want, and the most efficient way to do that is to be intersectional. This actually requires education, awareness, and deliberate practice, and we can all start at home on ourselves. And these are some tools you can use if you ever are interested in looking at your own implicit biases. They're fantastic tools to look at your own personal views on the world. And I can tell you, I didn't score as highly as I thought I would. I ended up identifying that I had some very much internalized biases that I was not even aware of. So even for minority groups, this is an extraordinary exercise to begin with. My work is mostly with medical schools, colleges, and research organizations to try and integrate intersectionality into medicine. And to be honest, it was born out of my own personal experiences, which is why I think it's really important to diversify healthcare workforce. It's important to engage with intersectionality experts in the design of policy, in the design of healthcare systems and research. And it's really important to protect vulnerable groups from micro and macro aggressions so they can thrive. I can tell you, as someone who's vocal in this space, it's not easy. It really takes a lot out of me personally, emotionally, mentally. And so trying to make sure that this work is not, delegated to people of minorities or from a particular minority groups is really important. It's something that we all should be doing together, and protecting individuals within the healthcare sector who have to deal with this on top of the current pressures we're dealing with is really, really important. So it's important to listen to, respect, and value the opinions of those individuals. And when you do bring them in and they say something, it's most important that that is validated, acknowledged, and actioned, so that those people don't get fatigued and stop speaking up. In my mind, the future that we need to aspire to is to acknowledge the limitations in the current evidence and the work towards closing the gaps in our knowledge in medicine, and particularly in the healthcare workforce, to openly acknowledge and empathize with patients and colleagues about gender or racial trauma, and be able to appropriately manage this. To do that, we really need to establish diverse healthcare teams and systems that can combat gender and racial trauma, and to foster a positive working environment so that these individuals can thrive and, most importantly, lead. We really need diverse leaders to be able to make good decisions in the healthcare sector. So we need to deliberately try and foster these leaders, bring them in, engage with them, and help improve the teams that we put together to deliver healthcare, both from a research perspective, from a public health policy perspective, and from a design perspective. And so my last slide, I'd like to make the point that I think it's time to integrate intersectionality in all aspects of medicine, both from a workforce perspective, but also from a practice perspective, so we can deliver effective and compassionate care for all.
Thank you, Nada. That was awesome. Let me just get my video going. Beth, maybe if you can get that happening. Wow, so much. I was scribbling madly. I definitely think we're going to need a copy of that. I'd love to go and have a look at some of those references that you made. I don't even know where to start. That was a very, very insightful presentation. And I guess what I'm really excited about now is that we can add to that from with our panel discussion. So with that, what I'm going to do is introduce our panel, our other panel members. So in the first, we have Dr. Natalie Yap. Natalie is a pediatric registrar in Victoria, and she has a very strong interest in global health, gender equity, and leadership. And she also has experience working in a diverse range of health-related organizations. Natalie is committed to gender equality and women leadership, and she's also been selected to represent Australia on behalf of the Medical Women's Association at the World Health Assembly, the UN General Assembly, and the UN Commission on Status of Women. Natalie also sits alongside Nada on the Gender Equity in Health Leadership Committee for Women in Global Health. So welcome to the panel, Dr. Yap. Our third panelist is Melanie Funk, and Melanie is one of my colleagues and NPON representatives on the committee. Melanie is the Managing Director of Eczema Support Australia. Melanie put her human resources career on hold for her two children, to look after her two children who have chronic allergies and eczema. And now Melanie focuses on raising her children, and then she has the great full-time role as well of developing a support network for other families that are affected by eczema. So welcome to you, Melanie. And then our final panelist, which I'm very excited to invite, is Michael Holdway. Michael, great to have a man's perspective in the group, Michael. So thank you for joining us. Michael has managed executive search assignments for over 14 years and has completed many campaigns for high-profile organisations across government and statutory bodies, health, education, and the not-for-profit sector. Michael does specialise in these sectors, and he understands the unique requirements and high profiles of these positions, and has been a great supporter of the not-for-profit sector. Michael is from Searchlight Recruitment. So with that, I think what I might do is I might direct a couple of questions as a start to both perhaps Natalie and Melanie, if I can direct to you as a first off. If you can maybe both, and Natalie, if we start with you, describe how your work in the field and how you've experienced being a leader as a female in the health system, and I guess any perceptions that you can take out of this.
Thanks so much, Hayley, and I wanted to congratulate Associate Professor Nada Hamad on a wonderful presentation, a lot to pack in there in a short amount of time. As Hayley mentioned, I'm from Victoria, so I'd like to acknowledge the traditional owners on the land on which I live and work, the Wurundjeri people of the Kulin Nation, and pay my respects to the elders past, present and emerging. So as a female doctor in training and a person of colour like Associate Professor Hamad, I've always sort of had this kind of interest in gender equality and the intersection that has with women in leadership and health. And as a result, I've been fortunate to be able to work in the policy and advocacy space around this area, and have been fortunate to attend different conferences at high levels from the United Nations in Geneva and in New York. And I think something that really identified as an important factor is the importance of open discussion, collaboration and accountability across all sectors. And that's something that I've tried to bring throughout all of my work. As both Hayley and Associate Professor Hamad have mentioned, you know, women in leadership are still underrepresented in Australia, and women make up 75% of the health workforce, which is a significant percentage. And of that, about 39% are CEOs of private hospitals, 45% of women are board chairs in public hospitals, and 38% of state and federal chief medical or health officers are women. So there's still some work to do in this space. I think from a personal perspective, I'll just share a few insights. And I think, you know, most women, and obviously I'm talking from my perspective, have experienced some level of gender discrimination, which they may recognise or might just be part of the male-dominated world that we live in. In terms of from a clinical context, I think sometimes I forget, and I'm not sure if this is relevant for other people, that I don't see myself all the time as a minority race or someone who should be treated unequally. So when something unexpected happens, it sort of still takes me by surprise. So, you know, for example, a few weeks ago, I was in theatre receiving a baby, and the theatre tech came up to me and started talking to me in Chinese and not English, and they were a Caucasian male, which just completely took me by surprise. You know, firstly, I didn't know this person, they didn't introduce themselves to me, and I also don't speak any Chinese languages as a first-generation Australian. So I think that really highlighted to me that I also still have some things to work on, because in that context, I didn't really have anything to say back because I was so shocked. But just thinking about how small things where there's an intersection between gender, race, LGBTQI, disability can affect you in your day-to-day life, and just having an open discussion with people about these conversations, including your colleagues, to sort of learn how other people experience different situations and people have responses. And I think it's always important to have no assumptions and come in with an open mind. So yeah, that's a little bit about me. And yeah, I think it's, you know, really important that we reflect diversity for women in leadership positions. Otherwise, will underserve women populations who are also a minority, and also perpetuate, you know, the inequitable health system that we have in Australia.
Thanks, Dr. Yap. Melanie, did you want to comment?
Yes, absolutely. I'd like to perhaps start with saying, wow, what a wonderful presentation by Professor Nada Hamad, and the insight from Dr. Natalie Yap. Two key words that I've taken from this has been intersection. I obviously need to learn a lot more and understand that a lot more. As Nada highlighted, it's probably not an area in Australia that we are all completely familiar with that concept. And having that well-researched, sophisticated, and yet also personal perspective, and I think that's the second word that I've taken from this. The perspective today is really important to take into account. So I guess I'd like to share a little bit about, from my own perspective and my own personal experience, what it's like being a leader, a woman in advocacy, leader in health. So as was introduced, a career as a managing director of a patient support organisation was not actually the career that I had anticipated. I have come from a background in human resource. I was human resource manager until my career took a sudden turn when my children's health deteriorated to a point where they needed 24/7 in-home care. So that was a bit of a surprise to me, that my career would suddenly go off track like that so quickly. But eventually that life experience was the inspiration that founded Eczema Support Australia. I saw a huge gap in the support services in Australia. And I'm sure that there are many attendees at this conference who can also relate to how their own patient support organisation started, perhaps as seeing that need from a parent's perspective and a mum's perspective, let alone for the wider community. So I actually became a leader in the not-for-profit sector and in the health system without any background really in that. I'd never worked for government, I'd never worked in not-for-profit before, not specifically in the healthcare system. So I found that there were a lot of challenges with that. And one of the key challenges was trying to navigate the system as somebody who I felt was a bit of an outsider, I guess in this case, a bit of an other, as Nada alluded to earlier. I went from a really rewarding career in human resources to basically a volunteer unpaid job initially, a mum trying to do the best I could, and really this career change to becoming Managing Director of Eczema Support Australia was certainly just as, if not more demanding, more responsibility and more workload than my previous career. But what I also found was that it was exhausting. A highlight though was we founded Eczema Support Australia late 2015, and it was actually when I went to the inaugural National Patient Organisation Network Conference in 2019 that I felt that I gained the confidence and the connections that I needed to take our organisation to the next level. And I think that's something to keep in mind here, that connections and the confidence is about that support. And that was a level, I was able to take that to the next level where we could do effective advocacy. And the session before was so full of inspirational, stellar advice from those panelists in that session on advocacy. But there has been times as a leader, as a woman, as a leader, and as a mum, where I felt that my role as a leader has been appreciated and valued, but there's been times where I felt that it's perhaps not being considered quite as significant as maybe other CEO not-for-profit roles. And I just want to assure anybody out there listening, and I'm sure many will relate to this, that those volunteer founders, those mums who started in a similar place that I've started, their work is just as valuable, it's just as extensive, and it's very impressive. So be reassured that your work is worth it, even if you're not always recognised. But I say that with a bit of a caveat. There's only so far passion can take you. You can start something with great passion from the right place, but it's not sustainable and you will burn out if you don't get the support. So I guess in relation to my experience as a woman in this health system, my take-home message from this question would be our health charity leaders, particularly our women, need support as well.
Thanks, Melanie. Yeah, I mean, coming back to what Nada said earlier when she spoke about, really asking who we serve and treating others with the way that they want to be treated, not the way we feel they need to be treated. And I think you touched on those points as well in your own words. Again, something insightful. Michael, I think we will throw to you now. It'd be great to get your perspective, someone who, as an observer in this sector, what do you see as the sort of trends in recruitment of women in leadership roles, and why are there more women in leadership roles in the not-for-profit sector? And, what impact does that have? I've got a couple of others, but we'll start with that.
Thanks, Hayley. I think I might start by saying, prior to working in the recruitment industry, I also worked for around 10 or 11 years in the human services industry sector. So I guess I've had a lived experience working inside organisations, particularly when there's been a higher proportion of women in that workforce, which isn't necessarily reflected proportionally at the executive leadership level. So I guess I've been in that system. My experience in recruitment in this sector, and probably none of this will surprise any of you, a lot of what I'm about to say is anecdotal and has sweeping generalisations. I think the positive trend is that there is a rising awareness of what, you know, a diverse and inclusive recruitment process might look like. I think traditionally, for example, you know, when organisations would advertise a position and, you know, you have a male-dominated response rate, you know, the defence was always, well, we didn't get enough women applications. And I think for me, that's always been reflected in, you know, women and men will approach advertising differently. You know, there's the anecdote around men will see, you know, 1 thing out of 10 that they can do and think they're great for the job. And women might look at, you know, I can do 9 of those things, but not that one, so I won't apply. I think that what that's done for me, I guess, in some examples of really good practice, is that organisations have perhaps been a little bit more proactive around how they try to attract people to their positions. And so, you know, there's some examples of really sort of gender neutral language around, you know, attracting, say, kind and compassionate leaders, which may resonate more with women, as opposed to, you know, business oriented and hard-nosed commercial leadership, which would probably tend to attract men. I think with the amount of different media advertising channels now, there's an opportunity, I think, to, you know, spread the advertising into other channels so it's more visible. I guess what I'm getting at is that I think if we want the system to change and be more inclusive, we have to be more proactive. It's not just going to be about doing the same old thing and expect to get the same results. And so, you know, there are organisations like Women on Boards, for example. You know, so if I'm recruiting for a board position, inevitably, almost always I will advertise through Women on Boards to ensure that, you know, we have a long list and short list that reflects, you know, equal balance there. So I think there's partially around how that's attracting people. You know, when I recruit for a position, we advertise, but then we also have, I guess, the colloquial term of headhunting. So we'll proactively, you know, reach out to people, mainly women, who are, you know, maybe passive observers, you know, and the number of times I've heard a woman say to me, well, I saw that ad, but I didn't think I had X or Y, and so I didn't apply. And so then there's a coaching aspect, you know, when you have that opportunity to engage with somebody and say, well, actually 3 or 4 people referred you into this process to me, and I think it's something that you should consider, then there's an opportunity to take somebody through a process. And so, you know, I think there are organisations that I've seen have talent acquisition specialists who are doing similar things. So they're doing the traditional advertising, but then through networking are actually proactively approaching people for positions. So I think that's a positive. It doesn't happen enough, I think it's fair to say. You know, these are pockets of good practice, but it's certainly not, you know, system-wide. I think the other aspect that I find is gradually changing is the selection process. You know, often it will be men in decision-making positions, whether they be board chairs or CEOs making decisions. And so, you know, setting up a methodology that, you know, is inclusive and actually tries to promote people's values and skills as much as their self-promotion skills. You know, in the interview situations, men are far more likely to self-promote. Women are far more likely to use language that is more inclusive and team-oriented rather than using lots of I statements. And so I think organisations that are aware of their own systems are more likely to be able to put in place processes and practices that encourage, I guess, better decision-making, more inclusion. So, for example, what I've seen in some organisations is where they will use, you know, either an independent chair outside of the organisation. They'll, in some occasions, will use consumers of their services to actually sit on interview panels and assist in that decision-making process. So you tend to get better decision-making, but I also, you know, absolutely understand and respect that there's a long way to go. There's lots of organisations that have, outstanding policies and procedures that tick a compliance box, but doesn't necessarily flow through into the behaviours of their organisation when they're hiring. I've got a client that's asking me to provide some training to some of their middle management who are in hiring manager positions, to assist them to talk about, better process, better practice, so it's more inclusionary. So I think there's some positives happening. What's reassuring for me, I think, and again, this is a generalisation, but I think, Gen Y women leaders coming through the system, in my experience at least, are far more confident, far more assertive, and really clear about, what is the role, what is the organisation that they're going to be attracted to. I think the reverse of that is organisations need to be better at, I guess, promoting, a better work-life balance, flexible working conditions, parental leave policies. I mean, I think it's a given that, the majority of women are still, have most of the child care responsibilities. And so I think there are some positive changes. You'll start to see, you've already seen, gender equity roles being recruited for an organisation. So hopefully that addresses some of the systemic issues within organisations. So that's some of my experience. I probably should stop talking now. I'm mindful of time.
Thanks, Michael. Professor Nada, and actually, if I can just open it up to everybody, if you do have questions for the panel, please pop them in the Q&A, because we will address them to the panel. Prof Hamad, we have a question for you. In the wide range of your inclusion of multiple segments of our society in your mission, may I ask if or how stigmatized diseases might fit or be included?
I think this is a very good question. And, I have to say that my evolution in understanding and learning about intersectionality, I discovered all sorts of things as I started to open my eyes to some of those issues. And it's important to kind of appreciate, why are certain diseases stigmatized? For a long time, we've tried to destigmatize mental health, but there are other stigmatized health conditions that really don't have a good reason for why they're stigmatized. The stigmatization comes from misconceptions, poor analysis of the science and the data. And in my mind, what patients might feel as stigmatized is not necessarily always what doctors stigmatize. And just looking at that from both angles is fascinating. So including health conditions in that paradigm is really important, by analyzing whether there is a perception of stigmatization, if there is discrimination in society and cultural overall around those diseases, and what that means in the patient and doctor interaction, or the clinical interaction with the healthcare system. And one of those examples in my mind is twofold, and this is one that's personal, and I will tell you this. For example, mental health. We all have been talking about destigmatizing mental health for a very, very long time. And, during COVID, we started talking about burnout of healthcare workers and how terrible this is. And we really need to support healthcare workers who are observing a significant amount of moral injury, watching what's happening to really sick patients and in general, the community, the public, etc. And one of my colleagues said to me, it's really important that you maintain your health by seeing a psychologist and maintaining your resilience and making sure that you are okay. And I thought, this sounds like a great idea. I need to practice what I'm preaching. So I went and saw a psychologist, and I said, you know what? I'm okay, but this is stressful and I'm tired. And we had a conversation. And my income protection came up for review. And my broker said to me, oh, they got a report to say you were referred to a psychologist. That's a mental health exclusion. So sorry, if anything ever happens to you, you're stuffed. And I thought, what? There was no diagnosis. There was no nothing. So these biases come from places you don't even expect. And so it's important. It would have been good for my healthcare physician or GP to say to me, you know, this is good, but you need to be aware of some of the sociocultural stigmatization that happens outside of this room and what that might mean for you. And I personally have taken that on board in my practice. So when patients come to me with a situation they want to diagnose through genetic testing of family members or any of those things, I say you have to be cautious. You know, you may wish to know these things, and it's important for you and your family planning, but you got to make sure you understand that some of these things, when they come through, will create biases for you outside of this healthcare engagement. So some of the research that I do is qualitative. So I talk to patients, I try and understand their perspective, their experiences, and that research is very much lacking in medicine. And I hope that in time, this will be valued just as much as the drug therapeutic studies that we do, because at the end of the day, we're trying to deliver healthcare. And if you're not listening to your patients and asking patients what's going on for them, you're missing half the story, if not more of the story. And that's really dawned on me late in my research career, and I'm ashamed to say that, but I'm very proud that it's something that I really integrate into my practice and my research now.
Thanks, Nada. Yeah, I had a similar experience. Thought I was doing some good and getting some counselling to be a better leader. And little did I know it affected my health insurance and life cover. So yes, these biases, they do happen. Natalie, maybe if I can ask you, what do you feel we all need to do in our roles to ensure gender equity?
Yeah, so I think, Hayley, that's a pretty big question. So I might try and put her through a few pointers out there. I think I mentioned earlier, you know, it's really important to collaborate as a healthcare professional myself with all the different sectors. So this includes obviously civil society organisations, not-for-profit, non-government organisations, and see how we can better collaborate together in terms of the agenda for advancing women in health, leadership, as well as, you know, advocating for our female identifying patients, as many people have identified in the chat. Women present later, are misdiagnosed, and often health professionals may not feel equipped to be able to communicate effectively with women. I think it's also important, if there is something that's pressing on your mind or something that you're really passionate about, to reach out to your local MP and organise a meeting, and you can write a letter as well on behalf of your organisation or on behalf of your colleagues. I think it's important to think about the barriers and overcoming those barriers, and you know, the additional duties shouldered by women. I think Melanie also identified that she was in a volunteer position, so you know, women often take on these roles which don't have any financial compensation, so thinking about ensuring equitable access for women to leave entitlements, as Michael has mentioned, you know, flexible training for health professionals and particularly doctors from my side of things, ensuring breastfeeding facilities are available at workplaces, and ensuring that women are included in the policies and co-design at all levels. So this doesn't mean tokenism, this means sort of meaningful engagement of women in those positions, and having people accountable to including women, and ensuring that we've got, you know, evidence-based processes and approaches for those decision-making processes. So I think that's probably enough from me, and yeah, I guess, you know, intersection is always important, so ensuring appropriate representation from all groups.
Thanks, Natalie. I just picking up on something you said, I might throw a question to Michael. Michael, just in regards to levels of pay, how are you seeing any trends or progress in this regard?
I don't think there's no easy answer to that one, Hayley. I think part of that, I think, is to do with, I guess, internal practices and promotional practices and how people are measured for their performance. And I would suspect internally that, if you had to sort of say, well, who is going to negotiate harder for a pay rise, it's more likely to be a man than a woman. I think women tend to be more selfless and their values better aligned to, if there's additional resources, it should go into service delivery as opposed to their own pay packet. So I think part of that is a values aspect. I think if I looked at people when they negotiate for a position, if they are a preferred candidate, again, men are more likely to negotiate harder for a greater pay rise. But I also think there is a trend developing, as I said earlier, with Gen Y women who are, really assertive about what's important to them and what their skills are and what their values in the marketplace. Now, again, I expect that hopefully that trend will continue. But I think it's a really difficult one. I think internally it's around internal structures and how they measure people's performance and how they remunerate them. Externally, as I say, apart from the anecdotes around men negotiating harder for themselves, I don't think there's a clear trend from my experience, at least. I think part of that too, Hayley, is around, you could probably extend this out to, human resource practitioners and where they sit and fit within organisations. And, if they've got a seat at that table and they are influential and listened to, again, you're more likely to see some of these policies put into practice. But I still think that, it's still one of those professions that isn't valued as highly as, say, a finance person might be, for example. So I think there's a couple of aspects there that hopefully will develop over time. But, again, I don't think it's a trend yet.
Can I just
Melanie,
comment
did
there?
you want to comment? Yes, go ahead.
Yes, it's just interesting. Our CFO, our chairperson, is a male for Eczema Support Australia, and he has been for many years extremely frustrated with me with my own inability to put a value on my contribution. And I'm a human resource manager by background, and we don't expect good organisational outcomes if we undervalue and overwork our employees. So my question to myself and to everybody here is, why do we expect people like myself to do and put in hundreds of hours of work, it feels like every week, without valuing our own contribution? We need to encourage and mentor and support and connect our women leaders, and I think this is a perfect platform to do that.
Can I make a very brief comment just in response to what you said, Melanie? The kind of work that you do is extraordinary and is extremely valuable to the healthcare workforce, and not just the workforce, but in general public health. And what I find interesting is that this is a theme and trend in society and cultural in general. The kind of work that women do, which is value-based work that women are compelled to do because they must, is considered free labor. And that's in the home, that's, in COVID certainly been highlighted, as we were told we had to homeschool, but also be doctors and nurses and serve the public without any consideration of what it means to have to do both with that additional request. And, I find it interesting that we don't know how to put a value on that work. And I think it's because as a society, we need to reframe the conversation now. This is the right time to do it. You know what, during COVID, the majority of the workforce is female. The majority of the voluntary labor and the value-based labor is done by women, and we need to put a value on it. And not necessarily just from a financial perspective, but from a policy perspective. I want to see people like you in the room when healthcare policy is being made and when decisions are being made about designing the healthcare system. Because
that's right. And the problem is, at the moment, where do we get that support? We can put a value on, but then how do we actually see that value come to fruition? And I think that's a whole nother conversation that needs to be had, because we'll keep doing the work. If we can't find the funds, we'll still keep doing the work anyway.
I think you're right, Melanie. And look, we could talk about this all day. I wish we had longer, but unfortunately, we've come to the end of this section. I just want to say a massive thanks to everyone on the panel for your contributions. And I think this whole conversation around gender equity and diversity, and that it needs to continue to be had. And so often we shy away from it because we go to extremes. And I think we just have to come to middle ground. And I think coming back to what you said as well, Natalie and Melanie, it's about working together to do better and being in the room to have those conversations. So keep knocking on the doors to get into the rooms to have those conversations. Thank you so much to our panel. I'm now actually going to hand over to Monica